Here in the clinic, I am not a typical diabetic educator. I do things a little bit differently. I don't hold my own classes or bill for anything. I'm simply here to help and guide patients between their appointments, keep them out of a hospital, things like that. So I'll be going over a few tips and tricks that I use that just make life a whole lot simpler for my providers and my patients. So the next slide. So the first thing we're going to look over is a glucometer. So this seems simple, but to someone who's never used it or seen it, you know, it is a little scary. So the life of a glucometer is typically 1 to 2 years. Sometimes when my patients say, you know, their blood sugars aren't reading right, I ask how old their glucometer is, and they'll say, oh, it's about 10 years old. Well, that's part of the problem. So getting them a new glucometer can definitely make their blood sugars a little more closer together, make it seem a little, add to their A1C a little bit more. Unbeknownst to a lot of people, you are actually to calibrate with control solution every time you open a new bottle of strips. That is something that we don't typically tell patients and is not widely known, but that is recommended to keep their glucometer calibrated. We recommend that you do wash your hands before testing. That can make a big difference on the blood sugar readings. If you use alcohol, we recommend to wipe away the first drop of blood and use the second drop to test your blood sugars. And change your lancets with each test is what's recommended by the glucometer companies. A lot of patients don't do that, so I at least beg them to change it daily. If you're checking 4 to 5 times a day, you know, you can use it that day, but each morning, please use a new lancet. A lot of patients come in complaining that their fingers just hurt. Well, with a dull needle, it does get a little challenging, and that might make a big difference for them. Also here on the side, you'll see a picture of a hand. It's recommended that you test your blood sugars using the side of your fingertip, not the pad and the tip of it. You have a lot less nerves there on your side, so it's not as painful. So recommending just the change of where you're testing your blood sugar can make a big difference for the patient. Another thing about glucometers is that the FDA requires 95% of the values to be, give or take 12% of the reading for any blood sugar above 75. So for example, if a blood sugar is 200, the meter can read anywhere between 176 and 224 and still be considered accurate by FDA guidelines. So for my patients, that's very frustrating for them. You know, if they're on a sliding scale, you know, a blood sugar reading in 170s versus 224 will make a difference on the amount of insulin they take. So I try to explain to my patients that we look for trends, not the exact readings. So check your blood sugar. We do the best we can with the tools we are given. Take your insulin. You know, if we find that oftentimes it's way too much, then, you know, we will back down on your blood sugars. So I try to explain to them that if you were to check your blood sugar on finger 1, 2, 3, and 4, you will get 4 different readings, but we are looking for trends. So try not to focus on and get fixated on the number itself. So next. So the next topic would be understanding the numbers. So many patients aren't given their actual ranges that we are shooting for with their blood sugars. So before your meal fasting, we are looking for readings between 80 and 130. 2 hours after, we are looking for readings under 180. So I have my patients, you know, check your blood sugar. What is it before? Your blood sugar can rise up to 60 points after giving insulin and still be a good insulin dose. So that's important for them just to look at it on what is our goal. Also, your A1C on the right, there are multiple different ranges of what they can be, but to show them that, you know, your A1C of 7% is about a 150 blood sugar on average. Next. Next topic would be diet and carbs. And many people walk in here and say, what should I eat? So that's really hard. Everyone's different, everything's different, but for the most part, a blanket statement would be for women, you get 45 to 60 grams per carb per meal and 1 15-gram snack per day. For men, you get 60 to 75 grams of carbs per meal and a 15 to 30 gram snack. This says 1 or 2, but we stick to 1. So that's kind of a blanket statement. You know, if a patient's just diagnosed with diabetes, that's a good starting point. Oftentimes here in America, we are eating way more than that. So this will most likely decrease their carbs, decrease their calories, and lead to weight loss, better blood sugars. So just giving them a point to start. Another simple point that can be pointed out is carbohydrates. So there are 3 different types of foods that make up carbohydrates. The first one would be sugary foods and drinks. A lot of patients come in here and, you know, they're still drinking regular pop and they wonder why they can't control their blood sugar. So it's really important to make them realize that it's not only food, but the juice you drink. That typically orange juice is good for you, but when it comes to diabetes, orange juice really raises your blood sugar. The next one is starchy foods. So breads, pastas, potatoes, rice, and corn. A lot of meals are basically based around those foods. So if that's a base for your meal, that's why it raises your blood sugar so high. And the last one is fiber. However, this is a good staple to your meal plan. You do need it, but it is made up of carbohydrates. Another thing we get asked a lot about is fad diets. What do you recommend? We have, you know, new intermittent fasting. We have the keto diet. We do not recommend any fad diets. The only one that we would come to recommend would be the Mediterranean. It has a mostly plant-based foods, fresh vegetables, fresh fruits, low carb, high main source of fiber and protein. So that is the only true fad diet that we recommend. Also, the DASH diet is something good to shoot for, and low carbohydrates. If ever you are, you know, decreasing your carbs, that's helpful. We do not recommend no carb because you do need carbohydrates in your diet for energy and things like that. So we don't recommend no carb, just low carb. Next. Another thing that patients is portion control. So here in America, everything is bigger and better. So as you'll see here, 20 years ago, a regular bagel was 3 inches. It's now 6 inches. So, you know, we tell patients, eat a slice of bread. We're talking about a normal small slice of bread, not the ones that are doubled in size. So they really need to know, what are we talking about when we say, you know, a small or a piece of bread. A muffin also has, you know, expanded in size. Sodas used to be 6.5 ounces. Now we're opted to get 20-ounce large. A cup of pasta versus the 2 cups of pasta that is you typically at your Italian restaurants. Also, another easy way to help patients portion control is your fist is typically about a cup. I do recommend that, you know, they go home and experiment with this. You know, my hand is very different than their hand. So you really need to know how to portion control in a reference. So, you know, if you measure out 3 ounces of meat and put it and it's half your palm. So that's a recommended 3 ounces would be half your palm versus my 1 palm. Sorry, my light went out. And then there's a few other tips and tricks there that'll show you portion control. Once again, these are guides, but your patients can't go home and measure. It's just an easy way. You know, you're out and about, you don't have your scale, you may not have a scale at all. So these are just a few tips and tricks to help them with portion control. Next slide. This also shows you portion. I just went to the grocery store this morning looking for apples, and lunchbox size is what a normal apple is actually considered now. So 1 apple typically has 15 grams of carbs. Most apples you see in the grocery store now are what is a large apple. That has 30 grams of carbs. So that's double serving. So patients really need to look, measure, weigh, and get an idea of what they're truly consuming. Another idea would be Another idea would be writing down all their foods, keeping a food log. Here's a simple, what is your blood sugar before you eat? What did you eat? And what is your blood sugars 2 hours after? Even with a lot of my type 1 diabetics, you know, it may be pizza, it may be pasta, it may be a type of cooked fish that causes their blood sugars really to spike. It's a lot helpful to write down what's going on when. And then remember, you know, when I have that meal, I may need to do things differently than what I normally do. So it can be super helpful just to jot these things down, make notes of them, keep a food log for them to refer back to. You know, you may only eat that meal once a month, but you may not remember. But if you write it down, it's a lot easier for us to control your diabetes on a case-by-case basis. Next slide. So looking at medications, diabetes has so many medications coming to market. And a lot of patients don't think about how diabetes medications affect different things in the body. It's not just plain blood sugars. So there are some that prevent the breakdown of GLP-1s. That's a hormone produced in the intestines. There's others that improve the body's response to insulin, decreases the resistance. There's others that improve the liver, muscles, and fat cells' response to the insulin. Others that lower the amount of sugar that the liver releases. Others that help the kidneys get rid of the sugar. Others that help the pancreas release more insulin, and then others that slow down the digestion. So oftentimes patients see, we've started on one medication, we add another, but their blood sugars are just out of control, their diabetes is getting worse, and they're not doing as well or as much as they can, and that's not the case. Diabetes medications may work for a few years, and then, we've exhausted that resource in their body, and it just doesn't work anymore. So diabetes is a progressive disease. It does worsen even if you've done everything you can to keep it in check. So we try to reiterate that to our patients and let them know that this isn't something that you're causing. This is just par for the course. So oftentimes we do have to add medications just like blood pressure. Unfortunately, we take one, add another, but we don't take the other one away. So combination therapy for diabetes is very common these days. Next. A few points about taking medications. We start patients on insulin, and we don't think about all the other things that comes into play. So taking insulin at the right time, 15 minutes before a meal for analog insulin, 30 minutes for regular. A lot of our pediatric patients that are coming up from peds, when kids are little, you don't know how much they're going to eat. You don't want to give them insulin for their whole meal and they take 2 bites and be done. So coming up from pediatrics, we learned that a lot of patients are still taking their insulin afterwards, basing it off, what they did eat, which is fine, but in the adult world, you're usually going to finish your meal. So taking the insulin 15 minutes before your meal allows it to be on board when your blood sugar is going to spike at its highest and the peak is at a correct time. So talking to them about when they take their medication at the accurate time can be helpful. For the older population, if they're using an insulin syringe and having problems seeing, there are smaller insulin syringes, such as a 0.3 milliliter or a 0.5 milliliter syringe that make the numbers more spread out, easier to see, more accurate dosing. So that's something we could take into consideration. If they're using an insulin pen, many patients walk in and they've been using an insulin pen forever, but they've never tested their needle. So every time we use an insulin pen, I recommend that you put the pen needle on, twist it up to 1 or 2 units, and make sure that you see insulin coming out. With an insulin syringe, we can see that the syringe is empty, but because a pen is being used multiple times, we can ensure that they did receive their dose. So testing the pen needle each time is going to ensure that they did receive their dose. Another hiccup I've come across is a patient, pushing the insulin pen in and then taking out and twisting it back down to 0. I never would have expected them to do this. So ensuring that they are pushing the insulin pen in, pushing the button until the dial is back to 0, holding for 5 to 10 seconds, and then removing the insulin pen from their skin to ensure that they did receive their dose. If patients are on medications for a long time, so we want them to avoid scar tissue, stretch marks for injectable medications. If their blood sugars are very erratic and they say, yes, I am taking my medication, and it's just being absorbed differently. So insulin's not absorbed as well in scar tissue. You may get the whole dose one day and not get any of it the next. So avoiding scar tissue, stretch marks, if someone has a particular spot that they give themselves their shots every single time, ensuring that they rotate sites is very important. Also, how long have you been using that pen or vial? For insulin, once you pop that top, it's good for 28 days out of the refrigerator. So if someone's been using the same vial for 9 months, that medication is no longer going to be effective. And that's a question that, sometimes I ask when their blood sugars are all of a sudden no longer controlled, especially if they're on low doses. How long have you had this vial open? Maybe opening a new vial, the medication will be more potent and you'll see a lot of changes in blood sugars. So the next topic is be honest. I often start with my patients of how much insulin are you taking? And they want to say, it's in my chart. So I don't want to know what is written in your chart, what are you instructed to do? I want to know what you're truly doing. Are you getting in your 4 doses of insulin a day? Are you missing lunch every single day because you don't have it with you or you're not home? So I really need to know how much medications you're truly taking. Another thing is, do you understand how to take it properly? We give patients sliding scales for insulin. You know, if your blood sugar's less than 70, eat your meal first, then take your insulin. So there's a lot of stipulations on taking medications that sometimes can get overlooked in the simplicity of it. So it's very important to ask our patients, do you understand what we're asking you to do, and can you repeat it back to us? Write it down, put it on your fridge, make sure you have a copy in your purse to take with you if you're out and about, to make sure that you are getting your insulin doses. So next, setting attainable goals. So in diabetes, we want you to cut out your high carbs, your sweets, your sugary drinks, exercise 150 minutes per week to lose weight, check your blood sugars 4 times a day if needed. Those are our ultimate goals, but those sometimes aren't attainable. If someone is not checking their blood sugars at all, eating whatever they want, asking them to go to those 3 tasks is going to be a complete life changer, and it's most likely not going to happen. So we start simple. Check your blood sugar daily for me. Cut out 1 soda per day. Limit desserts to 1 to 2 per week. Exercise 1 to 2 times a week. Set alarms to take your medications or test your blood sugars. Simple tasks like park farther from the door, take the stairs. You know, these aren't going to fix things immediately, but they will at least get us closer to our goal and make the changes not seem so huge that they are unattainable. So anything's better than what they've been doing. So if we can get them to make small changes, we can at least start to make progress towards our ultimate goal. Next. So this is kind of like an overlook of a year of what you should do for your diabetes. So every 3 months, you should see your doctor, check your blood pressure, get your weight checked, check your skin to make sure you aren't, you know, injecting any hematomas, causing scar tissue, and get your A1C checked if your blood sugar is not at goal. Then every 6 months, if your blood sugar is at goal, you can stretch out your A1Cs every 6 months and see your dentist. Every year, you should have a physical exam, a foot exam, check your cholesterol, liver, and kidney tests, have your eye exam, your hearing screen, your flu shot, and then a mental health check. That's a big thing for some people to wrap their heads around because they don't want to look at the mental health side of things, but diabetes is a chronic disease and it can take a toll on you, you know, having to take care of yourself and coping. So our next topic, I believe, is coping. So next, healthy coping. So a simple thing that we can do to help patients start to cope with this disease is to learn about your diabetes. What can you do every day to manage it and move forward to reach your goals? Develop coping skills. You can read Coping on Stress. It says how, so this is from a webpage that I'll give you, but it gave some ideas for how to cope with the stress. Stress actually affects your blood sugars very commonly. So patients don't understand that, you know, if you are going through a stressful situation, it's not that you are failing on multiple levels of uncontrolling your blood sugar too. It's the stress that's actually causing the high blood sugars. And then get support. There's a lot of free support out there for diabetes that's not utilized, and I'll point you to how to help your patients utilize those points on the next screen. So next, so a few helpful apps. I pulled most of this information from Novo MedLink. It's provided by Novo Nordisk, and it has patient information out there that you can download and print to give to your patients, all about everything from learning about diabetes to administering insulin, healthy coping, diet, exercise, carb counting. There's a lot of good information that's free out there. Lilly Diabetes also offers the same. If you like their printouts better than Novo MedLink's, I think they do have a really good carb counting. The American Diabetes Association also offers links out there. So if you go to either of those 3 websites, you'll be able to find some patient information that may be broken down simple enough for your patients to understand and really absorb. There's an app for everything these days. So Novo MedLink and paired to create Cornerstone for CARES. There's an app out there that it can link your glucometer to it, so you have it right on your phone. You can get reminders, healthy eating recommendations, lifestyle choices, set reminders to check your blood sugars or take your medications. And if you register for the Cornerstone for CARES, there's a free diabetes support program that diabetic educators can reach out to you. They can talk to you via email, text, phone. I think they even use Zoom to make calls, and you can get free diabetes education if you want it. So there on the right is the phone number that your patients can call to get that, or they can just register for Cornerstone for CARES either online or through this app. So it makes it a little more fun. You know, it's something new, something easy on their phone that they have with them at all times. The other helpful thing we have here is Calorie King. So these books have been around for almost a decade now. Carbs in foods haven't changed. So even if you have a 2009 version of the Calorie King Fat and Calorie Carb Counter book, it can be helpful. It includes fast food. So if they're out eating, they can kind of go to that page, see how many carbs are in their foods, and help make better choices. There's a website for that, and there's even an app. Free. You can have your carb counter right there with you at all times. And it makes it a little bit easier just to kind of be aware of what you're putting in your mouth. So we recommend that to a lot of patients, our younger population, even our older populations that have smartphones. They can download that, and it makes it a lot easier than carrying a book around. So that is all I have for you. Is there any questions, concerns, anything I can offer help with?
Thank you so much, Sheree. That was excellent. And the resources you provided in the last slide is super helpful. Like you said, there's an app for everything nowadays. I'm always really blown away by all the advancements in that aspect. But we did get a few more folks hop on. So I was hoping we could maybe do quick introductions for those of you who kind of joined on a little after the intros, and then we'll jump into questions. So Donna Buchanan, would you like to introduce yourself?
Hi, I'm Donna Buchanan. I'm a disease management coordinator, registered nurse with Population Health in Morgantown.
Excellent, thank you. Dr. Poliwal?
Hi, this is Dr. Himanshu Paliwal, family medicine at Fairmont.
Thank you. And Dr. Katragada? I believe you're muted. There might be a mute button on your bottom left screen. Zoom used to let me unmute folks, but now it just asks me.
Yeah, I'm an internal medicine MBA Fairmont Clinic.
Excellent, thank you so much. Glad you all could join us. So does anyone have any questions, comments, thoughts for Sheree and her didactic? Feel free to use the chat feature as well. We got a chat in from Donna saying it was super helpful, so thank you. I do actually have a question for you, Sheree. So yesterday we have a monthly metabolic group meeting, and one of the case presentations was about a diabetic patient, and they had tried a ketogenic diet, but they sort of lost that incentive and that, I guess, energy to continue with the low carb diet. Do you have any best practices or incentives, recommendations for patients who kind of lose that motivation and kind of get them back on track?
So yes, the keto diet is very hard to do. It is extremely low carbs. Our doctors kind of work closely with cardiology, and it's not exactly recommended because ketones are very hard on your arteries and veins. So we don't recommend the keto diet. We do recommend the Mediterranean diet. It does add some carbs, yet still healthy in that manner. I've learned from listening to a few of these places and doing my own research that getting on the scale every day actually kind of helps keep you on track. You can say if you had a bad day, you gained a few pounds, all right, well, today I need to do better. So at least getting on the scale a few times a week can be recommended to help you keep on track. Once again, these silly apps send you notifications and do recommendations. There's group chats out there. You can meet with people that are going through the same thing you are. You're really getting the external support that you can still get while quarantining at home by yourself. Maybe get some motivation. They recommend all kinds of different exercise programs that are available, online, on YouTube, things like that. So trying to go out there and getting support. Doing it alone is hard. That's why they always recommended a diet buddy, but things like that I think can be a little more helpful, get you motivated a little more, but you have to really, truly want to do it yourself. So, looking at the mental health side of things, oftentimes you have a hard roadblock on what's preventing you from doing the things you need to take care of yourself. So talking to a therapist, a counselor, a support group, things like that may not be as accepted in America as we would like it to be, but it can be very beneficial once you learn to find the resources.
Absolutely, thank you. Any other thoughts or questions, comments? All right, well, I don't want to hold you guys any longer than we need to, but I appreciate you all joining. Thank you so much, Cherie, for that excellent didactic. I'll attach it to the recap email that I send out shortly here in the next couple of hours. And as usual, we'll post our sessions on our YouTube page. So if you, for some reason, want to go back and listen in on something, we'll have them posted there for you all to view as well in your own free time, if that's helpful. So thank you all so much. Just a quick announcement. Our next session will be on September 9th, and Renee is going to provide our didactic on diabetes and sick daycare. So keep an eye out for that reminder. Just a little quick announcement as well. We're launching a memory health echo that is sort of more focused around Alzheimer's. So if you are interested in joining in for that session as well, just shoot me an email and I'll send you all the registration link to join that. So thank you all so much. Thank you again, Cherie, and we'll see you guys next time.